Hello everyone, my name is Ifeoma Okeke. I'm a telemedicine family nurse practitioner and I work with healthcare corrections in Western United States. And this presentation is in fulfillment for the DMP course for Maryville University. The topic for the DMP project is reducing adverse drug events in incarcerated adults. During the course of this presentation, we'll be going over the following outline subtopics: abstract, the introduction, specific aims, methods, results, analysis, discussion, implication to nursing practice, implication to future research, and the references. Starting with the abstract, this gives us a general overview of this project, including starting from the background down to the conclusion and findings. Adverse drug events are considered a significant patient safety issue, and they are most common during transition of care, and they cause preventable harm to the patients. The incarcerated patients are not excluded in this. The purpose of this project was to evaluate the effectiveness of implementing an evidence-based guideline using the Agency for Healthcare Research and Quality, Medications at Transitions and Clinical Handoff, MARCH, Medication Reconciliation Checklist, in reducing the adverse glycemic events in those patients returning from community hospital admission at this project site. The method used for the study, it was a retrospective chart review conducted on the EMR of the incarcerated adult patient diagnosed with diabetes and who returned from community hospital admission. The results showed improvements post-intervention. There was a 23.8 increase in the number of patients who received medication reconciliation post-return from community hospital admission. There was also a decrease in the number of patients who missed the medication reconciliation, thereby reducing the risk of adverse drug events from 42.5% to 18.8%. In conclusion, the study showed that poor medication reconciliation leads to adverse drug events in patients transferring from one care setting to another, and inadequate knowledge and implementation of a standardized medication reconciliation process reduced adverse drug events. Going over the introduction for this project, adverse drug events cause preventable patient harm. And it's not just among the incarcerated patients, it is a global public health problem. According to the Centers for Disease and Control and Prevention, adverse drug events cause approximately 1.3 million emergency department visits and 350,000 hospitalizations every year. There is also 3.5 billion expenses on medical costs in adverse drug events annually. More than 40% of the costs related to ambulatory ADEs could have been preventable. Most adverse drug events result from poor medication reconciliation process, and several studies have shown that medication reconciliation is the gold standard intervention for addressing medication errors during care transition. Medication reconciliation was initiated to improve medication safety and minimize medication errors during transition of care. The specific aims for this DMP project was to improve medication safety during transition of care. Secondly, improve medication reconciliation process. And lastly, reduce adverse drug events. The methodology the method used for this project, after obtaining internal review board IRB approval from both the project site and the university, data collection and interventions were completed and implemented respectively. The study was considered exempt from human studies regulation by the IRB. The DMP Scholarly project was conducted as a prison clinic in the Western United States, and the sample included incarcerated adult patients 18 years and older and their electronic medical records. It focused on incarcerated adults who faced adverse drug events related to inconsistent medication reconciliation during transition of care. And to improve the patient outcome, the author implemented a quality improvement program at the clinic in collaboration with other stakeholders of medication reconciliation. A formal in-service training was provided to the providers and other stakeholders on the new practice change, the compliance expectations for utilizing the Agency for Healthcare Research and Quality MARCH medication reconciliation checklist. The MARCH checklist was subsequently embedded into the electronic medical records, and a flyer for medication reconciliation tool, once subscribed to the nurses, was placed in the shared holder for patient comprehensive medication list. The design used for this project was a quantitative exploratory design. Participants were not engaged and patient information was not extracted. The author recorded only the minimum necessary data to accomplish the project goals. The data collection instruments include the data collection sheet, and all potential patient identifiers were also removed and were not collected for this project. Methodology continues. Protection of the human subject. All confidential identifying patient information were removed and not included. Ethical consideration, including protecting the patient rights and the security of data information, was in place. No informal consent was required, as this was a retrospective chart review. The researcher, who is a telemedicine provider on the project, utilized convenience sampling for this study, and there was no conflict of interest. Methodology continues. Interventions was evaluated using the data collected post-intervention, and the data trends showed improvement in medication reconciliation for those patients returning from community hospital admission post-intervention. The researcher designed an Excel spreadsheet to record and display the results collected during the retrospective EMR evaluation. The characteristics of the sample. Validity evaluated the extent to which concepts are accurately measured, and reliability evaluated the consistency of the measurement. The outcomes were evaluated by a retrospective chart review of the EMR intervention. Analysis. All data were analyzed using the SPSS statistical software. There were no missing data, additional exclusions, or adverse events on data values. The DMP project was a comparative quantitative research design that was carried out using a pre- and post-intervention data to determine if there was improvement in medication reconciliation on this population post-intervention. The Agency for Healthcare Research and Quality Medication at Transition Clinical Handoff MARCH medication reconciliation checklist was the intervention evaluated and was transcribed using non-parametric statistics. Categorization of numerical data was recorded into an Excel spreadsheet. The data point from the EMR review helped provide descriptive statistics and to evaluate the intervention compliance pre and post intervention. Analysis continues. Table 3 shows medication reconciliation, the frequency of medication reconciliation that was done pre-intervention. It shows that out of the 78 patients or data reviewed, that 44 patients had medication reconciliation after they returned from community hospital admission, and this should have been yes for all the patients. But 34 patients did not have the medication reconciliation, and that was pre-intervention. The second table, table 4, shows the frequency of medication reconciliation completed post-intervention. After 4 weeks of intervention, a post-data collection showed that 63 patients had medication reconciliation done post-intervention and 15 patients did not. Some patients still missed medication reconciliation, but there was a decrease in the number of the patients that missed medication reconciliation. In comparison, there is a valid percentage difference in the pre and post intervention data. It is shown that 55% of the patients got medication reconciliation pre-intervention, while the number increased to 78.8% post-intervention. Going over the upper TLZ test that was used to evaluate the difference between the two proportions, a directional form of chi-square test was done, and the values from the sample data for this project favor the alternate hypothesis, since the p-value is far much less than the significance level. Hence, the null hypothesis was rejected. Please see table 1. Going over the results. After reviewing the pre and post intervention data, implementing a process change such as the Agency for Healthcare Research and Quality Medication at Transition and Clinical Handoff, March, it shows there was an improvement in medication reconciliation, especially for patients transitioning from one care setting to another. The March checklist improved medication process in these adults 18 years and older diagnosed with diabetes and who returned from community hospital admission. From the project findings and the projects, it was shown that the p-value of 0.0010 is far less than the significant level of 0.05. Hence, the null hypothesis was rejected as shown in the previous slide. There was sufficient information to suggest an increase in the ratio from pre to post intervention, as will be shown in the next slide. Figure 1 shows a bar chart representing the difference in the pre and post intervention data, showing that more patients had medication reconciliation after their return from community hospital admission using the March checklist. On the discussion, the vision for this project was to create awareness of the poor medication reconciliation process among this vulnerable population and to improve the overall medication safety using an evidence-based guideline. The March checklist helped define each stakeholder's roles in medication reconciliation process, including the roles of the provider, the pharmacist, the nurses. It also outlined the roles of the patient, although for this project, the patients who are the participants were not actively involved. This was a retrospective chart review. The project was a comparative quantitative research that was completed using the pre and post intervention data to determine improvement in medication reconciliation on those patients post-intervention. The outcome of the risk prospective EMR evaluation noted a decrease in the percentage of incarcerated adult patients returning from community hospital admission who missed their medication reconciliation. The result of the test showed statistical significance between the group pre and post intervention, with an overall improvement in medication reconciliation and reduced adverse drug events related to poor medication reconciliation process in this population. The implications for nursing practice. The findings result from this project reveal the importance of an effective and standardized medication reconciliation process for all patients, especially for the vulnerable ones. The incarcerated adult patients are vulnerable as they rely on their healthcare team for most of their care. The ongoing importance of improving, it also shows the ongoing importance of improving medication safety during transition to prevent adverse drug events, which eventually lead to medication errors. Adverse drug events are preventable and they cause great harm to the patients globally. They also cause unnecessary and preventable healthcare costs. Hence, one of the National Patient Safety Initiative and goals is medication safety for patients regardless of their care setting. The implications for future research. This in-depth analysis demonstrates that a standardized medication reconciliation process is attainable and is vital in providing quality and safety in medication and during care transition. Establishing an educational intervention as part of an annual mandatory training for all stakeholders of medication reconciliation will result in progress towards reducing adverse drug events. This impact also supports the use of educational intervention to improve the overall patient safety. It is a great way of disseminating information, implementing and carrying out practice change, all geared towards improving patient outcome. We'll go over the references that we used for the study. The first one is from the Centers for Disease Control and Prevention. The second one is another study by Goyeso et al. 2020 on standardization consensus of a hospital drug database. The third one is a mixed method evaluation of medication reconciliation in primary care setting by Giuffrido et al. 2021. The last two of the references used for the presentation is the development of a tool to assist medication reconciliation in a rural primary care clinic, a Journal of American Association of Nurse Practitioners by Jarrett et al. 2019. And the last one is another study, patient safety at transition of care by use of a compulsory electronic reconciliation tool in an academic hospital by Lady et al. 2015. And with this, will be concluding here, medication reconciliation is the gold standard for preventing medication errors, ensuring medication safety. However, this has to be standardized. This has to be passed around that poor medication reconciliation leads to adverse drug events. And this is supported by doing educational intervention as a mandatory training for all stakeholders to always be sure we're getting it all right together in creating a culture of safety for the patient, regardless of their care setting. Thank you.